No, so.
Okay, so welcome everybody. It's Wednesday, 25th of October, 2023. I'm Sharif Awad, bariatric surgeon at EMBMI Derby and educational lead for BOMSS. And it gives me great pleasure to introduce the team who will be presenting tonight in just a moment, but just advance notice of our next educational webinar. So it will be the Journal Club on the 8th of November with Prof. Rubino from the King's team. And the MDT, so they'll be presenting the Journal Club on that date. And then on the 4th Wednesday of November, we're going to be talking about the Nissen sleeve, okay? And we've got a super expert who's going to be doing that talk. But without further ado, I'd like to welcome Mohamed Ali, upper GI surgeon at Hillingdon, and Alan Askari, bariatric surgeon at Luton. And they're going to take us through some of the fantastic work they've done to get the Apollo EndoStitch device implemented within an NHS service. So Mo and Alan, thank you very much for presenting at the educational webinar tonight. I'll hand over to you.
Thank you very much, Sharif, for having us. Ladies and gentlemen, it's an absolute pleasure and delight to be here, so thank you. As Sharif has very concisely alluded to, we wanted to talk a little bit about implementing endoscopic suturing to essentially treat dumping syndrome. Now, a lot of us will have seen patients after bariatric surgery who have either reactive hypoglycemia or dumping syndrome, and they can be quite challenging to treat. So my colleague and I, Mohamed Ali, and myself will talk through what we did to try and establish pelvis as part of a greater team, a wider team, of course. We don't have any disclosures. We've got nothing to disclose. Now, we'll talk a little bit about, very briefly, about what dumping syndrome is and what reactive hypoglycemia is. Of course, everyone here being very well versed on the topic, we won't labor the point. And then we'll move on to talk a little bit about, we'll talk a little bit about the overstitch and transoral outlet reduction endoscopy, how to set up a service, and talk briefly about our experience and the future of what we like to implement. So dumping syndrome and reactive hypoglycemia, these are terms really that can sometimes be used interchangeably, but there are actually quite nuanced differences between the two conditions, even though their symptoms and signs they present with can be similar. Essentially, dumping syndrome happens due to a rapid transition of food going from the stomach into the small bowel. Now, of course, in a gastric bypass, when you've got a very short distance between the esophagus and the small bowel, that tends to happen more than in the sleeve, where you've got a longer transit. Reactive hypoglycemia is essentially the excessive drop in blood glucose after eating, and there's a rebound that's usually due to a very big insulin spike after you have a big spike in your blood glucose, and the insulin spike then brings your blood glucose crashing down. It's important that we do investigate other causes for these symptoms, that we don't just assume with the dumping syndrome. Now, the scope of the problem is somewhat difficult to really quantify. Certainly, reading from the literature, there is at least 10 to 40% of bariatric patients after surgery will have symptoms suggestive of dumping syndrome. The reason why it's difficult really to quantify that is because there may be even greater number of patients who do have these symptoms in a lesser form, or it is transient, so they have it for a few months after surgery and disappears. But certainly there is plenty of publications that suggests that it really is not an uncommon thing. It can happen relatively commonly. Now, one of the ways that the severity, or rather even diagnosis of dumping syndrome is undertaken, is using the SIGSTAT score, which has been around for about 50 plus years after the work done by Dr. Eric Sigstad. And essentially, it's a checklist of symptoms that gives you a composite score as to the likelihood of you having dumping syndrome. So you've got kind of a 16-point checklist. And certainly anything more than 7 is highly suggestive of dumping syndrome. But if you're scoring less than 4, the chances are you probably don't have dumping syndrome. and you should really be looking for other diagnoses. It also does stratify severity. Now, certainly 13, 14 points would get you towards the very significant symptomatic end of the scale, but that is just something that most people agree on rather than absolute official set marker, if you will. The management can be difficult. It's multimodal and part of a multidisciplinary team and encompasses dietary and lifestyle changes, medication, and interventional. Dietary changes could be patient education, advising patients to have more bulky foods that have got a lower glycemic index so you don't get that big sugar spike or that rapid transit into the small bowel, eating slowly and consciously and regularly. And also, there have been a range of medical therapies that have been tried, including PPIs to try and slow down transit a little bit, somatostatin analogs, so octreotide, antispasmodics, Acabo, GLP-1 agonists have also been tried as well, with very variable success in patients. And the evidence, whilst there's some evidence behind some of these medications, the evidence, must be said, isn't terribly robust. Interventional, traditionally, the only real choice we had was to undertake surgery, which would mean to either refashion the gastrojej, to reform the gastrojejinostomy, or to convert to a sleeve gastrectomy. This is in patients who've had a bypass and you reverse them and then go to a sleeve, or which is very rarely done, I must add, or go back to what the patient was like anatomically, so a complete reversal. Now, of course, all of these kind of procedures have their own problems. For example, there's absolutely no guarantee that by converting the patient to a sleeve gastrectomy, then they're not going to have similar symptoms, even though it's less rare, it's less common in sleeve gastrectomy. And of course, a reversal of bypass is fraught with its own problems, and the patient will almost certainly regain weight. And there has been case reports and case series, as you can see on the right-hand side, and it's kind of been amalgamated into a systematic review, which was published 7 or 8 years ago, which does say it's possible, but of course it has its own issues. So one other possible solution in the intervention category would be to undertake an endoscopic approach, and that's using a transoral outlet reduction endoscopy, or what's referred to as TOR-E. And essentially, that is a device attached to a gastroscope going down into the mouth, into the esophagus and stomach, and trying to alter the outlet. What we mean by the outlet is the gastrojejinostomy. It's the diameter of the joint. And essentially, it involves an appropriately investigated patient selected and consented to make sure they haven't got another cause for their symptoms, and this is truly reactive hypoglycemia or dumping syndrome. And now, while it can be done under heavy sedation, general anesthetic is really what's done in most units still. It needs to be a diagnostic gastroscopy beforehand to make sure there's no other pathology accounting for the symptoms, such as ulcers, inflammation, possibility of even new onset Crohn's in the gastrojejinostomy joint, etc. And there are various systems to use. We will describe the overstitch by Apollo that we used. And of course, post-procedure, there's antiemetics, analgesia, a proton pump inhibitor, and overnight stay, although some units do it as day case. However, we, starting out, thought it probably sensible, but at least at the beginning, that we do keep patients overnight. So what exactly is it? Well, the area that we want to concentrate on, I hope you can all see this, is that green circle that we can see at the gastrojejinostomy. So that's what we mean by the outlet. And the idea is that we use the endoscopic suturing to narrow this joint so that we can reduce the diameter in the hope of slowing down the food bolus. And therefore, by slowing it down, we're physiologically preparing the body for the glucose and insulin response, so it's less dramatic. Essentially trying to get a more tempered hormonal response, and also there's going to be a less osmotic change in fluid shifts once food hits the small bowel. The idea is that all of this combined is going to give you less symptoms. So how's it done? Well, the first one we'll describe the setting of the service in a short while, but the actual procedure involves doing an OGD. So you look down at the gastrojejunostomy, which is what we can see here on the left side. And then using an argon marker, you essentially mark the circumferentially around the diameter of the gastrojejunostomy. The reason why we mark is we're trying to create scarring. And as we all know, of course, by burning the mucosa and causing scarring, scars will contract over time and narrow the diameter. On top of that, we're going to deploy some stitches. So that's the third box that you see from your left. We deploy sutures, and usually 2, occasionally 3, but certainly be unusual to need more than that, is enough to narrow the joint. And at the end, you can see on the far right slide picture, sorry, is a narrow joint. So ultimately, what you want is to mark the area with the argon to generate scarring. You want to deploy your sutures safely and to narrow the diameter, but not that it's completely occluded. How do you know when it's tight enough? Essentially, it's tight enough or it's good enough when you can't really get your gastroscopy through. So that's what you want to use. It should be quite difficult to get the gastroscopy through. Because bear in mind, after you finish the procedure and the patient goes home, so weeks and months afterwards, the scarring will continue to occur. So the diameter that you see at the end of the procedure will actually be narrower in a few weeks or months' time. So here's the argon circumferential burning, as we talked about, and you want to do it essentially within 1 centimeter margin. So you don't really want to creep up towards the esophagus, and you don't want to be too far away from it, well into the gastric pouch. You want to be at the right margin. And as we talked about, it generates scarring by damaging the mucosa. The sutures, you can essentially do it any which way you like. It can be just simple interrupter sutures or a case of short running sutures. You can do continuous, and you can even do purse string. And as we said, what's successful? When is narrow enough? When is it you've done a good job? And that's essentially when you can't get a diagnostic gastroscopy through. And just a little bit more about the purse string. It's a bit more technically challenging. I don't think we've done it, but it's been described, and certainly Dr. Bansi Proctor has got some experience with this. It essentially involves going in an anti-clockwise or clockwise fashion and deploying it. The advantage is it gives you a good visibility of the defect, and you can get a good narrowing that you like, and it's quite controlled. The problem is, of course, that any one of these 10, 12 sutures that you put in is a bit loose or cuts through, then you're not going to have a good closure. So you've got to make sure that every single one is spot on. So this is a diagrammatic version of how it's done. So you see the gastric remnant in the gray in the background. You see the gastroscope going down. That's the zone that we're talking about, the gastrojejunostomy. And essentially, you're deploying sutures to narrow the outlet, which you can see on the left here in that little mini picture within the picture, within the video itself. So that's the idea. You're narrowing the outlet, you're narrowing the exit. And the evidence behind it is mainly in a meta-analysis or systematic review and meta-analysis that was published last year, just over 13, 14 months ago, 15 months ago, rather. And it was relatively small numbers, 236 patients spread across 6 studies. And the follow-up was only about 8 months. And they usually use 2 to 3 sutures, most of the studies described. Overall, what they did find, however, was that there was a significant reduction in the 6-stat score. The 6-stat score, which I'm sure many of you will recall and know, is how we essentially diagnose and stratify the severity of symptoms in dumping syndrome. And the procedure time was about 37 minutes, plus or minus 10 minutes. The intra-procedure adverse event was relatively rare, about 2.5%, and that was mainly they had difficulty to actually do the procedure because of either the gastrojej joint was either too difficult to navigate, or it was the pouch was too short. There was one case of equipment failure. Just to add, it wasn't from the Apollo system, but there was also an occasion of bleeding as well. Overall, however, I think what's important is to remember that nearly 1 in 10, or just over 11% of patients required further intervention. So in some patients, you may do the TORI and the overstitch, However, you need to follow them up because not all the symptoms may be resolved in one go, and you may need to do further work. On that note, I'm going to hand over to my colleague, Mohamed Ali, who's going to take us through the rest of the presentation. Thank you.
Mohammed, I think you're on mute. Can you just unmute and start again? Thank you.
If anyone's got a bingo card, now's the time to mark it. So yeah, that was why you need to do an overstitch, and hopefully the rest of this talk is going to talk to you how we actually got about to doing it and what the essential steps. It takes a village essentially. There's a lot of stakeholders that you need to identify, and we'll go further on as to why that is. But you, apart from the surgeons and industry, you also need to liaise with your endoscopy department, your administrative staff, your dietitians, clinician, nurse specialists, your bariatric physicians, etc. And all of that with looking after the patient in mind. Hold on, let me just stop this. And looking at with the patient in mind, and these members will then on form your MDT, as these patients need to have exhausted their conservative and medical management before they proceed to an intervention. In our experience, we went and spoke to the endoscopy department, spoke to the clinical leads, got asked for some equipment to be loaned, asked for own Pentax reps, the APC rep. I can't remember what the APC machine used to be called, but they have a rep as well. You need to get them involved. They'll help you set up the APC machine the first time you're doing the procedure. You need to keep your theater staff up to date. You need to train them. You need to also liaise with your consultant colleagues, let them know that the management that this is going to take time. The meantime to do a TORI is 40 minutes. The first case took us 2.5 hours to set up. The second case took an hour, and then the third case took much less time than that. So the first couple of cases, just because everyone, even if you do regular advanced endoscopy in theater, even if you do balloon dilatation, even if you do things like that in bariatric patients in theater, it's still deploy balloons, etc. You still need some time to get your head around the platform, and you keep that in mind. It is advisable, and Apollo will tell you this, you need to get Novel Technology Committee approval. In our trust in Luton, they met 3 to 4 times a year, and we'll talk about the timeline. But yeah, you need to get all your paperwork ready. It's not just getting the kit, but there are a lot of things that need to happen at the same time. With regards to staff training, Apollo were very supportive in this through the representatives themselves. Sarah Mason, our regional Apollo rep, and Rory's management for whole of UK. They were very supportive. They delivered lots of teaching to us, to the staff, to the MDT side as well. They sponsored and continue to run the Overstitch course. I attended the first course in Southampton last year, and that was the kind of stimulus that how we brought the platform to Luton. The proctorship that Apollo offered, a proctorship from Christine Steer, who delivered to talk to us remotely. Dr. Dev Bansi's come for a number of cases to help us as well. It was very invaluable to us. We set a wet lab in our educational center with pig stomachs to have a go, and that's essentially the same jig that they used at the course at Southampton. So everyone had to got a chance to deploy the stitches and see the full thickness, what full thickness looks like on the endoscope and in the pig stomach as well from the outside, and got to practice both ESG and TORI on pig stomachs. And then we could also set up a dry lab to have a feel on foam models as well that they can provide. Now you've trained your staff, you've got your Novel Tech Committee, theatre management are happy to block 3 hours in theatre to do your 2 cases. The next step is finding your right patient to do this. And ideally, there'll be patients who have gone through your medical and conservative management pathway. They've been thoroughly investigated for their symptoms. They don't have any insulinomas or any other weird and wonderful causes for their symptoms. And we're definitely convinced they have dumping syndrome or reactive hypoglycemia. We avoided patients who've had reoperations or any further revisional work post their initial bypass. and we avoided sleeve patients as well. You may include patients with treatment-resistant marginal ulcers. Apparently, you can use the Overstitch platform for that. However, we haven't found the right candidate to try that on yet. In the workup, you need to arrange for diagnostic OGD to assess their GUJ diameter. Usually, they're very wide in patulous. You need to give them a 6-stat score that Alan has provided. There is nothing that is patient relevant, so there's a lot of jargon in the one that they have, so we translated it to a kind of non-jargony kind of version. We gave them that score preoperatively. We consented them in separate clinic appointments. We prepared the patient information leaflet as well, and they all underwent preoperative assessment for GA. We then also established a data collection data collection tool, as any project that Askari is in will have, and that's very important as well, because you need to keep an eye on how these patients do. To date, there's only one paper that reports long-term outcomes from Ivo Bukowski's group, and again, the number in that was 80 patients, and it's only 2 years follow-up, so it's pretty much open now for collaborative work. So again, as Alan explained, this is a jig that comes at the end of your OGD. There are tower where the needle's going in through, and a smaller kind of channel where the stitch is coming from. There's a helix that comes next to it that captures the tissue. When it reloops, I will explain again. So you need your equipment. There's a handle that controls the needle going in and out. It sits on the front of the scope, and you attach it with rubber straps. There's your needle there that goes in and out. If you play the video a little bit, it will retract. And then that's the helix that catches the tissue, approximates it into the jaws between these bits. That enables you to take a full thickness stitch. You need your argon APC machine, your CO2 insufflator. In our experience, CO2 insufflator was the rarest commodity that we had to actually loan from Pentax. And you need this insufflator to be the same as your original endoscopy stack, so you can't get Olympus on Pentax and vice versa. And the appropriate theater space. We stuck our cases at the end of a bariatric list. If you have a GA endoscopy suite with enough space and they're keen on learning and taking this on, you can also do that there. Our experience, these are not Apollo slides, these are our own TORI outcomes. This is how it looked like pre, and this is what it looked like post, to give you an overview of what as Alan said, a couple of stitches, and that's the end product really. We made initial contact with Apollo in October. Dr. Steer delivered a departmental online teaching on how she selected her patients and what her pathway was and workup was. We got Novel Tech during that time. Between October and December, we were working on Novel Tech committee application. We were arranging teaching for our surgeons and nursing staff, and we had already started the patient selection as well. In fact, we were also started patient selection. So once the Novel Tech committee email came out, we listed the patients, and within 6 weeks they were pre-op assessed. They underwent their pre-op assessment and got approval and consented everything. We did the first 2 patients in a single list, and then we ran out of time, so we had to do the 3rd patient in a separate list. But this is why I'm saying you need to be mindful. It takes much longer than you expect it would do. And then 3 months later, we managed to find everyone have enough time, and listed 3 more patients, and then underwent TORI. And that's everyone happy after the 2nd list, and very successful outcomes. To date, Luton's been doing Roux-en-Y bypasses since 2008, and just referrals alone to the bariatric clinic from last year, we've accumulated 66 patients with dumping syndrome / reactive hypoglycemia, with a median 6-stat score of 14. So these are all very symptomatic patients with common symptoms that could be very well attributed to dumping. 6 have undergone TORI, with I think 3 more are on the waiting list. And the 2 that we've started to see coming in for follow-up now have reported complete resolution of symptoms, and we're waiting for the rest to trickle back in. Certainly 30 and 90-day adverse events have been 0. So that's all very good. Obviously, it's not all rosy, and there have been challenges and learning and character development moments. Equipment to get from Apollo was fairly easy. The next challenge ahead is quantifying this in terms of funding with the ICB, if this is considered endoscopic or surgical revision of the gastrojudge. There is a code for surgical revision. There is a code for advanced endoscopy. Whether your managers are happy to attribute this procedure to either, that is a discussion to be had between your managers and the ICB. Coordinating human and material resources. It's basically 4 Venn diagrams with a very, very narrow common bit. The other thing was lack of established guidelines. Now, we found this was particularly tricky in patient selection. There's nothing out there, certainly in the States, where this technique has been prevalent for longer than in Europe and in the UK. There's no established guidelines, nothing from ASMBS. There's, I think, one guideline from Florida that's an internal kind of protocol for them, but there's nothing else. Learning curve and training. Again, this is a challenge that you have to kind of overcome by just time. And as with everything, the usual uphill battle with getting a new service up and running. But eventually we overcome it. And I think in Luton now, the current challenges are the ICBs and again, finding time and space to do these patients. With regards to patient education, patient selection. If you're starting a new career or new practice, that's usually the advice. Make sure that they've had the right dietetic advice, nurse specialist and psychology input, bariatric physician input as well. Starting an MDT perhaps for these patients is the way that we're going to advise or kind of imagine further on in the talk. Explain to the patients the pathology and the procedure. We had to cancel them to say that this is completely brand new. It's not experimental, it's well established. It's now part of NICE guidance, but you'll be introducing a brand new service to your hospital, and the patients need to know this. They need to know that there's experienced proctorship around. There are people who are the people teaching the people doing the procedure, have done about 400 procedures themselves. So you need to reassure your patient that they're not a guinea pig. And do a patient information leaflet. We have a 3-page patient information leaflet that we developed as well. For the future, a referral protocol, hardcore criteria with recognized funding. That's the aim, really. The endobariatrics is growing as a subspecialty, and perhaps its own tariffs and recognition needs to be recognized. Glucose monitoring as well, that's important, especially if you're talking about reactive hypoglycemia and establishing it as a diagnosis. These are expensive, and some patients may actually go and get them privately out of their own pocket. So we need to recognize this cost and do what we can to alleviate it of the patient. Administrative and clinical support. Let your theatre know, let your staff know. It needs to have its own protected slot and recognize. And discussion and education with the GPs, with the ICBs, and just growing recognition amongst the NHS. And in order for us to achieve this, we need formation of guidelines. So obviously BOMSS sponsorship, Delphi questionnaires, explore patient and clinician perspectives and what they think this is. And there's lots of education that's required, lots of workshops and support. That's how you build the perception, and that's how you build the point of view and the perspective, really. And ultimately, when this practice grows, there'll be multi-trust or national MDT, a standardized referral pathway that everyone can copy and everyone can follow. And as the practice grows, that also you can have an academic role, develop RCTs, and more importantly, record long-term quality of life and outcomes for these patients. And we're coming to the end of our talk now. None of this work could be really done without the support from our consultant colleagues. and importantly, the support of our valuable members of the MDT, the body of nurse specialists at Luton and Dunstable Hospital, our managers, and our, I would say, shout out really to the booking officer, Zana, for her flexibility and her ability to track the patients in time, and our bariatric coordinators and nurses. So thank you very much. And I think we open the floor to questions.
Thank you very much, Mo and Alan. Really fantastic, succinct presentation. Can I just ask you, I'll ask you 3 questions from me, and then we'll go to the questions from the audience. So the first, really fantastic turnaround time for your novel technology committee to give you approval within a month. So did you have any queries, concerns, questions, or was it the case that your application was so good that everything on there answered the potential?
We had a very eloquent representative and spokesperson to do the talking with the Novel Tech Committee. I think we had a lot of support from Apollo. So they had an email from NICE saying that actually the technique does not require novel NICE approval. It's recognized the procedure is recognized, and the technique and the kit is recognized. So you can go ahead without waiting for NICE. And we attached to the application our own literature review, which is essentially shows this is very safe. The risk profile is 2%, and even the risk that occurs is not very severe. And if anything, they might need revision, as in more stitches, if you want to achieve the desired effect, rather than taking someone to theatre and opening up their belly and things like that. And Alan, go ahead.
Sorry, I was just going to say, ultimately, is Mo's kind of said it in great detail, but ultimately, I think it's about preempting what the committee is going to look for. And so we try to do it that way around by trying to think, okay, what are the questions, what are their concerns, and have all those answers ready before, so that you don't have that to and fro of, is the kit licensed, is this been done before? Is it in trial effect? We had made sure that we'd done the literature research. We'd had nice, there was already nice approval. We had our colleagues from Apollo, who obviously were very experienced. We'd already talked about lining up a picture. We had already kind of looked at the need for it and talked about the cost. So every question they could possibly give us, they'd come back to us with. We'd already put it on the initial kind of presentation, so it was very difficult for them to have anything to come back to us with.
Yeah, great tips. And did you just put in TOR on the application, or did you also include, for example, endoscopic closure of candy canes and endosleeve?
We kept it specific, I think, for that particular one, but we also said that this is potential kind of development for those 2 procedures you talked about, in particular, maybe endosleeve. But I suspect if we were to kind of develop those 2 other services, then we would probably need to go back and say, look, we mentioned it as part of the TORI, but this is an extension of that. But we thought that if we were going to, I mean, we weren't really in a position to be able to get all 3 running up and going at the same time. And I think that would be challenging, just identifying the patients and counseling them and getting them through the MDT and everything else. For each one of those procedures would be challenging. Just to try and put a business case for all 3 together, I think we thought a bit too much. It's certainly doable, but I think our thoughts were that a better strategy would be to be very specific on that one particular one and get it done, and then make a success of it, and then go back and say, remember that bit of kit that we said we could do TORI with? Well, can we also use it for endosleeve and equally have all the right answers for them already before they ask the question?
Okay, no, that's a good strategy to go for. Last question from me, and then we'll go to the audience. ICBs and funding and procedure codes and so on. Did you need to liaise at all with the ICBs or /CCGs at the time to get approvals?
That's a hill yet to be taken. At the moment, the cost to do all the training and do these patients has been eaten by the department. In good faith that this will eventually turn back, but you have to do, it's a chicken and egg situation.
Okay.
We have to kind of buy the chicken this time, and hopefully we'll continue to make more eggs in the future.
Yeah. Okay.
I think once as this progresses in the near future, and it certainly isn't something that's going to go away. It's well established in the United States already in multiple centers. So this isn't something that's going to be a fad. It's going to go away. Okay, not every single patient who's got dumping syndrome is going to need a couple of stitches in their gastric pouch. Of course not. But the scope of the problem is so big that there'll definitely be, this is not going to be a rare thing. So with nice kind of backing, it's only a matter of time before the appropriate coding, the OPCS codes and the appropriate funds and tariffs will follow. But like Mo said, we had to take a bit of a jump doing it.
You did, yeah. No, it's fantastic. It's the only way, I guess, to move things forward.
The symptoms are very vague. I think if you actively go looking for these patients, you will build a database pretty quickly.
Okay. We've got 9 questions to answer from the audience. So can we do like a quick fire? And we'll literally just run through those in the next 8 minutes. So first question, just take us through the dietary protocol after a tour.
Yeah, I can do that. So it's the same after bypass in our hands. So we, again, PPIs, liquid diet for 2 weeks, and then build up as you would normally. Okay. And just keep them on liquid diet until the swelling and things calm down a bit.
Okay, and minimum unit numbers for gastric bypass units in order to generate enough patients with dumping syndrome, reactive hypoglycemia to necessitate setting up a service. Do you have any idea how many bypasses should a unit be doing or have on their database?
I don't think it matters so much as how many the unit's doing now or in the future. It's traditional because a lot of these patients are historical. It's what's been done in the past. And they don't necessarily even have to be your patients. So it may not be a patient that you've done a bypass on, but there'll be enough of these patients around. But if we say that, according to the literature, even if dumping isn't quite as severe as 40%, etc., even if it's in a region of 5 or 10%, certainly doing 1 to 200 in any unit, or having 1 to 200 patients who had a bypass doesn't necessarily mean you did it. It's going to be enough to run a service. Does every single unit in the country who does bariatrics need to have a dumping syndrome, reactive hypoglycemia, and TORI service? Probably not. But I guess long story short is there is not going to be a shortage of work here. We certainly need a lot more units than just a handful.
Okay. Surgeons or gastros doing these procedures? What do you think?
I think it matters to anyone, really. Anyone who's been trained to do it and has got, I think the thing to remember is as good as the procedure is, and there is some good evidence behind it, it's not just about the procedure. So it's not about surgeon or gastroenterologist. It's not the endoscopist, whether he or she is a surgeon or a gastroenterologist. It's about everything else that comes with it, because the dietitian input, the nurse specialist, the psychology input, anaesthetist, obesity physicians or endocrinologists. So you need to have all of that. The actual endoscopist, I don't think it matters as long as it's somebody who's been trained how to do it.
But I guess close interplay, if gastro are going to lead in this, close interplay with surgery so that there's access and backup for any complications that might
happen. Exactly. It needs to be part of a wider kind of obesity service and rather than just a standalone procedure.
Okay. Any data or anything you're aware of in terms of endobariatric procedures and nutritional deficiencies in the long term? Anything that you're aware of?
In terms of ESG, I am not aware of anything. Again, I can refer to Ivo's paper that published this year in terms of long-term outcomes for dumping. And basically they reported 2-year outcomes they haven't reported nutritional deficiencies, but they did report symptom recurrence in a third of the patients for, I think both roughly like a quarter here and a third there, but they're basically for the dumping and reactive hypoglycemia, a third of the patients report recurrence.
Yeah, I mean, ESG should not, I mean, we don't really know for sure, but should not be physiologically much different than a sleeve gastrectomy. And as we know, the nutritional deficiencies okay, they're not zero sleeve gastrectomy, but the rate isn't catastrophic either. And certainly with something like this, with an outlet reduction with TORI, you're not really changing the nutrition, you're not really changing the absorption mechanism. You're just slowing the process down a bit. So there's the same amount of food is still going to get into the small bowel. Your villi are going to do the usual things, and you're going to absorb whatever you absorb or not absorb, as the case may be. So it doesn't really fundamentally change that bit. All it does, it just makes it a little bit more of a relaxed pace rather than things just zooming straight from the esophagus down into small bowel, which is what is ultimately, we think, causes your dumping syndrome symptoms.
Okay. And question about assessing the diameter of the gastrojejunal anastomoses before you. How do you judge it and decide? So, patient with a high Sigestad score, but the diameter doesn't seem to be too large. What do you do with such a patient then?
We still there was a patient like that. I think we still offered them a TORI, and the idea is that, as Alan explained, this you're still slowing the rush of the food down, and that should still that should do something in terms of their symptoms.
So, so even if you determine that the size of the GJA isn't that wide, they may still be a benefit from TOR in very symptomatic patients. Yeah.
Yeah, because ultimately, what we're in, like you say, in very symptomatic patients, of course, if they're being managed conservatively or medical therapy and they're fine, then there's no real reason to go to do TORI. But we've got to remember what you want your end result at the end of your TORI procedure to be, and that's you can't get your scope through. So unless it's that narrow, in which case you probably shouldn't narrow it further, unless it's that narrow, if you can get past the gastrojej, then that means that is already wider than how it should be at the end of your TORI procedure were you to do one. So then that is really potentially a good marker you could do rather than, I mean, measuring things endoscopically is very difficult, isn't it, in terms of centimeters. But if you can get a scope through and they've got a lot of symptoms and they're very symptomatic, that would be wide enough for TORI.
Okay, question about whether you've used continuous or flash glucose monitoring before and after these procedures. Have you used those before? Should you use them? Do you have an opinion on that?
Certainly, some of our patients do have kind of the active monitor, of which there are several kind of devices out there. We do have some of those patients who are using it, and they're actually some of the 3 or 4 that are waiting for this procedure are in that category. Essentially, they've got more reactive hypoglycemia proven by the recordings on their device. So that's and part of our database is exactly that, is to, with their permission and consent, of course, is to get that data before and then get the data afterwards to compare what success we've had. Certainly, there are some, the numbers are small, but there are publications that demonstrate there has been an improvement in a more stable kind of blood glucose level before and after. But that's the 3 or 4 patients who are lined up.
Fantastic. And final question from the audience. Now, you delivered such a good presentation and done such a good sell for Luton. So are you looking for patients from other units then? Should we start referring to you? Is that the plan? Grow the service and be sort of regional/national?
I think our ultimate aim absolutely is to have a national service, and I don't just mean Luton. I think we need several national centres. Like we said, I mean, not that there's hundreds of bariatric centres in our country, unfortunately, even though we need it. But I don't think every single unit who does bariatrics needs to have the service ultimately. But Luton, Derby, or 1 or 2 units in London or Sunderland or Taunton, so on, is not going to be enough. We're going to need a good number of units that can provide a collective national service, and ultimately even have like a national MDT, as they do maybe with more kind of things like a sarcoma or something. So that's really what Mo was alluding to in his slides about the future. We certainly would consider referrals. Now, the funding is part of the issue, because one of the things that, of course, is that we need to convince the funders is that we're not doing it for those who've had weight regain, because that's the usual question we get asked. Patients regain weight. in the NHS, unfortunately, it's not funded. There's no funding for that. So the short answer is yes. We would love to. We will love to hear from you, referrals wise. Ultimately, can 1 or 2 units alone carry the workload of this nationally? The answer is absolutely not. We need a lot more than that. And I think that's what we need to do as part of BOMSS together collectively as a specialty to develop these services in key locations around the country.
Yeah, and there's a BOMSS endoscopy endobariatrics committee anyway that are working hard in the background. Mo and Alan, thank you ever so much for a fantastic presentation. We're bang on time. So thank you once again for taking time out from your Wednesday evening to present to us. Congratulations on setting up a brilliant service in Luton. And definitely lots of tips there for other units such as ourselves who want to go down this route also. So thank you again. A reminder for the audience, Journal Club, 8th of November, Prof. Rubino at King's, and the next webinar, 22nd of November, David Knocker will be talking about Nissen sleeve. Okay, good night, everyone. Thank you very much.
Thank you very much, everyone. Good night.